No, Joost Heijmen will start with making the case for IVUS. Thank you, Joost.
Okay, we'll start with making the case for IVUS, but honestly, I think we again need to make the case for imaging and not necessarily for one technique versus the other. But what I want to try to do is in the next 5 to 10 minutes at least to give you a little bit of a flavor what IVUS is, what the evidence is about, and why we think it's a proper technology for a wide range of patients that can help you to get better outcome. While doing that, I would like to start, following the extensive presentation of Mirvat on the data already, is that these data actually yesterday did not really come as a surprise, because we knew, as of already 2020, this is just one of the many meta-analyses that have been published on the topic, that the vast majority of data supporting the concept of imaging-guided PCI has been related to studies studying the effect of IVUS-guided PCI. This is just a pooled data set, over 27,000 patients, 9 randomized controlled trials, 10 observational studies, already attesting to the fact that IVUS-guided PCI decreased the risk of cardiovascular death by 33%, MI 39%, TLR 19%, and also stent thrombosis with 43%. So that, I think, attests to a robust body of evidence which was already available since several years, showing us that IVUS-guided PCI, what has to be said, mainly in more complex patient subsets, was able to help us to improve patient outcomes. Those were results up to 1 to 2 years, but these findings have been extended up to 5 years. And this is important because we learned that IVUS-guided PCI results that were superior at 1 year were durable, with sustained improved outcomes up to 5 years. Here, just some results from the IVUS XPL and Ultimate trials, some of the larger randomized trials on the topic, helping us to understand that the benefit of imaging-guided PCI, IVUS in particular, was sustained up to 5 years. So what about, and that's a little bit to the question we had just a few moments ago, what about the impact of IVUS-guided PCI in ACS? This is obviously one field that is still maybe a little bit open for debate, depending on how you define ACS. For STEMI, there are no dedicated randomized controls trials yet, but in patients with ACS in general, there is accumulative data, in this case, over 800,000 patients, mostly registry-based, by the way, that helped us to understand that IVUS-guided PCI showed a strong trend and actually a significant improvement, in this case in all-cause mortality in patients presenting with ACS. So that's what we knew as of earlier this year when we pooled all data on IVUS-guided PCI in patients presenting with ACS. And that's where I think yesterday's data was incredibly helpful in helping us to understand that when pooling all the data we just saw from the IVUS data, now also adding October and Illumian 4 to the equation, that not just imaging is able to reduce cardiovascular death, but even all-cause mortality with a relative risk of 0.75. So meaning a significant 25% reduction in all-cause mortality when imaging-guided PCI was performed. Second part of the presentation I wanted to share with you is the fact that I believe that imaging per se will not improve patient outcome. It's the fact that you need to pay attention to how you use the imaging in 3 stages throughout the procedure. And whether you call that the IVUS 1, 2, 3 essential protocol, MLDMAX, or any other protocol that may be introduced in the near future, it's basically all about the same thing. First, you start off with pre-PCI imaging in order to assess lesion severity and plaque morphology. Second, perform pre-stent imaging to assess whether your potential, if any, plaque modification was efficacious, and you determine the stent size, and finally you end with post-PCI imaging to attest to the fact that your PCI achieved a result that was as optimal as possible. And the relevance of the latter was illustrated in several of the previous IVUS trials, but this is just an example of Renovate, showing you that your event rate up to 3 years was 12% in the angio-guided arm, whereas in patients that achieved an optimal imaging result, event rates were less than half. Whereas in patients in which imaging was used but no optimal result was achieved, event rates were 9%. So this just to say that imaging per se will not help you to get better outcome. You really need to try to get an optimal result, and that also illustrates the efficacy of the, for instance, October protocol that was very stringent in forcing the operators really to get an excellent result. Here are just a couple of imaging examples to put those results a little bit more into a pragmatic fashion. Pre-PCI imaging, the key thing is that you start with assessing lesion severity. That's the basic concept of the first pullback you do. And that's where IVUS is a very easy tool to help you to understand the presence of calcium, which is likely the most important thing in achieving optimal stent expansion. On the left side here, a clear example of a lesion with a lumen area of 1.9, which is clearly insufficient, but more importantly, almost 360 degrees of calcium, which is very easily recognizable on the IVUS, attesting to the fact that this is not a lesion that you want to stent immediately. That's where the IVUS can help you to direct the type of lesion modification you want to do. In this case, we just took a trio non-compliant balloon in order to see if we could fracture the calcium. In this case, the IVUS was repeated. That's critical. If you do lesion preparation, you repeat the imaging. And that's, again, a big advantage of IVUS. There's no need for contrast, so that will not come at any price in terms of contrast load. You repeat the imaging and attest to the fact that the calcium in this case is fractured and this lesion can be stented. Only then you use, during the same pullback, the data to help you define a landing zone and size your stent. I will not dwell into all of the individual stent sizing algorithms, but what is critical to understand is that you learn to recognize what is healthy, as shown here on the left side, a healthy artery and IVUS, versus what is diseased. IVUS will show you the lumen, but IVUS will also show you the full vessel, which makes IVUS an excellent tool, due to its larger penetration depth, to not just see the lumen, but also see the full vessel. And you will be able to recognize, without doing any measurement, that the image here in the middle is a vessel with a significant plaque burden that should not be a landing zone for a stent, irrespective of the fact that the lumen area might be 6 here. In that case, you use the IVUS tools to find a landing spot that has a plaque burden less than 50%, and that is critical. If you use IVUS, pick a landing zone with a plaque burden less than 50%. Finally, your post-PCI imaging. 3 things are important. 1, minimal stent area. Minimal stent area, in this case 6.1. So we use the cutoff of 5. In all previous IVUS studies, everything above 5 was good and associated with better outcome. In this case 6.1, so we put that in green. MSA larger than 5 looks significant, or at least appropriate. In this case, this was the distal edge. Lumen area 5.9, you would say, well, that's not too bad if the area in the stent is 6.1, but the plaque burden here was way above 50%. So this was not an appropriate landing zone. And again, also IVUS with the particular newer techniques, high definition IVUS also allow you to see dissections. Obviously, smaller dissections with IVUS much more difficult to see as with OCT. However, they are visible in case they are relevant for somebody who's used to use the technology. Then what about stent expansion? I'm showing you this simply because of the fact that if you would calculate stent expansion, and with IVUS you need to calculate it yourself, and that's the big advantage of OCT, but you need to be able to interpret the figures. If you computate, in this case, stent expansion based on the distal reference, you would calculate 103% because the distal lumen area is 5.9, minimal stent area is 6.1. That's 103% stent expansion. You would say, well, that's good. Well, actually, I've just shown you this is not good. This is not optimal stenting because the stent ended in the middle of a plaque with a plaque burden above 50%. And that is something we routinely see, and that is something that has been shown to be a strong predictor of future target vessel revascularization. Finally, the relevance of this minimal stent area, I already alluded to the fact that in previous data, the minimal stent area above 5 is a strong predictor of proper outcome and significantly lower event rates as compared to patients with a minimal stent area below 5. And then finally, what I wanted to show you is how does that correlate to OCT. These are the results of the Illumian trial on the left. So if you look at the minimal stent area post optimal PCI in Illumian with OCT guidance 5.7 versus angio-guided 5.3, which was statistically better. But now take IVUS, a identical final minimal stent area with OCT 5.6. However, with IVUS, the operators for some reason were able to get better outcome with a final minimal stent area of 6.7. Whether this is truly relevant and will apply to the potential differences between the IVUS and OCT trials remains to be determined. What is important to realize is that Illumian was the first really large-scale randomized global trial, whereas IVUS, as well as most of the other IVUS evidence, was derived from Asian populations. So for those people who are still not convinced, I think it's important to highlight there are 4 large randomized controlled trials on the way. There is Optimal, a particular trial on left main-guided PCI with IVUS. There is IVUS CHIP, a large European randomized controlled trial, over 2,000 patients in which we just finished enrollment. Events are hopefully to be presented by the end of next year, IVUS and high-risk PCI. iSTEMI for IVUS and STEMI, and improve the US and now also global variant of a high-risk patient study with IVUS-guided PCI versus angio-guided PCI. With that, I would like to conclude, and thank you for your attention.
Thank you so much. You highlighted the potential differences between techniques, the lack of, you don't need contrast, you see deep in the vessel wall, the EEM, and the calcium, the imaging of calcium is straightforward. So which could be the potential benefits of OCT? How does it differ as compared to IVUS?
So thank you very much, and I want to thank Joost for proving my point that nobody can interpret an IVUS image. That's the problem. It's too hard to understand IVUS. And unless you have a Kiko in your lab and you'd use IVUS on every single case, you will miss these findings. Now, how can this make sense? How can a lower resolution device give you a better outcome than a higher resolution device? How can that be biologically plausible? Let's think about this. So, as Joost said, whatever algorithm you're going to use, whether it's MLDMAX or 1, 2, 3, these are the things that impact PCI. The morphology, the length, you got to go normal to normal, but you got to find normal to normal. Dissections, to treat a dissection, you got to see it. And then afterwards, you want to be able to make sure that the stent is opposed, so you got to be able to see the struts, and you want to make sure that you can measure the expansion without needing a PhD in mathematics. In order to integrate intravascular imaging into PCI, it has to be simple. That's why we made MLDMAX, so you can remember it and apply it. So let's start with morphology. Okay? We made MLDMAX simple for everybody to follow. Morphology. This is the simplest I could make IVUS interpretation. And I really tried. Okay? And what it includes is hypoechoic, hyperechoic, shadowing, whether there's a wall, but I'm the first to admit this is still hard. It is very hard to differentiate a hypoechoic from a hyperechoic lesion where the shadow is. Let's look at OCT. It's simple. You can see it. All you need to know is, can you see the circle around the vessel? If the circle's there, the artery's normal. If the circle's not, there's a problem. If it's in the wall, it's lipid. If it's diffuse, if it's well circumscribed, it's calcium. If it's in the lumen, it's thrombus or it's tissue protrusion. Simple. Now, Joost was the first to admit that the thing that we care about most for plaque preparation is calcium. Well, these are two exactly the same lesions. Nobody can tell me how thick that calcified plaque is by IVUS. It's impossible. But by OCT, I know exactly how thick it is. And we know that the arc, the depth, and the length of the calcium is an independent predictor of stent expansion. Check OCT. What about the morphologies, right? We want to know the different types of calcium morphologies because calcified nodules, whether they're eruptive or non-eruptive, are different. Sheet calcium is different from thick calcium, protruding, etc., etc. So on calcium morphologies by OCT can easily be determined and clinically actionable. But the fact is, it's just harder to do that with IVUS. Right? It's hard to see exactly where this calcium is, and as a result, it's harder to know whether or not I've modified it. Now, let's say we do modify it. What do you want to know? You want to know whether or not you fractured it. Okay, so on one side you see IVUS fracture. So you got to sneak around the lumen to look for this acoustic shadow that bounces around behind the wall. But with OCT, it couldn't be clearer. The fractures have a box pattern. They're really simple to see. Okay? So morphology, OCT. Now length, we basically use the same strategies. We use the longitudinal pullback. We try to find reference segments of the artery that look normal. If we do, we put a bookmark. If they don't look normal, we scroll around to try to find a segment of the artery that has a less than 50% plaque burden, and that gives us our normal to normal. Good. You do exactly the same thing with OCT. You try to find segments of the artery that are normal, but it's easier to see what's normal because if you can see the circle, the EL around the artery's normal or fibrous and you can land your stent there. It's easier to see the disease where you shouldn't land the stent. And as a result, what it does is it streamlines your procedure, and finding the EL is a safety net. Because if you can see the EL, the artery is a safe place to land your stent. And I don't have to measure the plaque burden by creating a bunch of circles. Ultrasound 1.0 and 2.0 find the EL for you. They make it easy. What about diameter? So when we measure diameter, we use a similar strategy. What we try to do is we look at our proximal and distal references just like we did on the length, but on one side we have to measure the plaque burden, like I said. And you have to do a sort of a calculation to make sure it's less than 50 or more than 50, whether you should use the media or the lumen. OCT simple. You see the external elastic lamina? You use the vessel measurement. You can't see the external elastic lamina? Use the lumen measurement. Lumen and upsize, EEL and downsize. Simplified algorithm. Now, one of the things that Joost said was very important, and it caught my attention. He showed in IVUS that the minimal lumen area by IVUS was a lot bigger. Well, of course it is, because IVUS oversizes by 10%. So just multiply that number by 0.90, and guess what? The numbers are exactly the same. So if you're not playing on the same playing field because of your scale, it's not fair. And that's why in Illumian 3, we gave everybody a blinded OCT at the end. And then we could compare apples to apples. And what did we find? Absolutely no difference. And here's the data, right? So IVUS, 40 megahertz IVUS oversizes your stent by 1/4 size. So it makes you put in a bigger stent. As soon as we did Illumian 3, we dropped that down and we found out it was no longer significant. So let's compare apples to apples, right? Apples to apples would be 60 megahertz IVUS against OCT. In all fairness, they have very similar measurements. We'll accept that. But most of the world is using 40 megahertz or even 20 megahertz IVUS. So how can you make measurements that don't actually equate to what you measured? 2 slides ago, I showed you the IVUS XPL data, which shows that OCT is extremely accurate compared to a phantom model. It means you buy a straw from McDonald's, it's 3 millimeters in diameter, and OCT will tell you it's 3 millimeters. But the IVUS might tell you it's 2.9 or 3.1 or 3.05 because all the crystals are different. We do agree that HD IVUS is the comparator to really compare apples to apples in contemporary PCI. If you want to be using high-resolution modality, let's make it a fair example. What about co-registration? Let's look at co-registration. Let's look at the difference between performing a co-registration between these two modalities. The only co-registration system available for IVUS commercially is 20 megahertz IVUS, right? That doesn't help you co-register. OCT allows you to look at the artery from the inside out and the outside in, and it reduces your geographic miss to less than 0.2 millimeters. What about our post-PCI for a medial dissection? Well, let's see how we measure a post-PCI dissection on IVUS. What we've got to do is we've got to find the edge of the stent. It's grayscale, and I've done several thousand IVUS, but look at that shadow. Is that plaque or is it a dissection? What about proximally? Is there a dissection there? Now, not everybody has a Kiko in their lab. Remember, this is sitting like 12 feet away from you or 6 feet away from you for you to make the decision. Let's find the same example and do it by OCT. The stent is already highlighted. You click your button, you look at the edge, the resolution is excellent, you can quickly determine whether or not there is a dissection. So the speed by which you can do your post-PCI optimization is meaningful. What about apposition? So we care about apposition, and the way we got to do it by IVUS is we have to do it manually. By the way, these are exactly the same case. These are co-registered images. So now I got to scroll through the artery, but every time there's plaque behind my IVUS image, I can't tell whether it's strepsipose, because I don't know if it's lipid or I don't know if it's space, right? So I'm guessing. Isn't the whole point of intravascular imaging to eliminate guessing? So there's too much guessing related with this technology. Let's look at OCT. OCT tells you everything on one slice. The white bar tells you it's fully opposed, let's move on. 5 seconds or less. And then we've got to do expansion, right? So when we do expansion, let's do an expansion in real time. So this is where you can, get your PhD in mathematics. I don't think interventional cardiologists want to be doing math during the case, right? This is a real caveat. And so what I'm doing here is I'm measuring the distal reference, and now I have to manually scroll through the artery and find the MSA. Isn't the whole problem in human error that Nick West is going to pick a different cross-section than I am, and Joost is going to pick a different cross-section, and then Nieves is going to pick a different cross-section? So what was supposed to be quantifiable and actionable has now become completely subjective. But what if we do the same thing, right, by OCT? The exact same assessment. So here we see 90% expansion. The OCT just puts it on the screen for you. It does all the math for you. 92%. I don't need to do any more. So you can see in totality, I did the medial dissection, the apposition, and expansion in less than 20 seconds. So this is how you streamline procedures. Now, in all fairness, these are two modalities which are very similar, but do have some features which allow us, just like a Swiss Army knife, to use the right thing in the right situation. Okay? Lorenz and Tom, both first authors of the consensus document, which have provided tremendous impact to the field, have said this and said, these overall do the same thing. We need to get good at them. If you're good at only one, that's okay. If you have both, get good at them. And they provide the same clinical impact. But there are some subtleties. And I think these are my opinion, but they're fair. The PCI guidance with OCT is faster, easier, less subjective, and more automated. And now with artificial intelligence, that becomes even easier. But there are certain situations where we have to admit that IVUS is superior. Like in chronic total occlusions, where we don't want to dissect the artery with a hydraulic dissection. In the left main, maybe not the distal left main, but it's certainly in the proximal or ostial left main, where we need to make sure we have coverage. Ostial lesions, we couldn't include those in Illumian 3 because we can't see them. And there was a big benefit in Renovate PCI in ostial lesions.